Welcome to AETCM, the emergency medicine channel. Today let us discuss about shock and its features and how to manage shock in emergency room. We know that shock has got different types of mechanism that also we will see. Shock is defined as a state of cellular and tissue hypoxemia. That is very important. Patients' cells or tissues develop hypoxia due to reduced oxygen delivery. Either delivery is reduced or increased oxygen consumption, or the cells are consuming oxygen more and more due to some metabolic activity or inadequate oxygen utilization. There are some toxins which can produce reduction in the oxygen utilization. There the supply is good and the delivery is good, but the oxygen utilization is reduced. So whatever it is, the tissue oxygen utilization, delivery, consumption, whatever it is reduced. That is shock. So most oftenly this shock is due to hypotension. In emergency room, mostly the shock is due to hypotension due to various causes. We will see that afterwards. So there are four main types of shock. One is distributive shock, cardiogenic shock, hypovolemic shock, obstructive shock. So we will see each one of them in detail and we will see what is the main problem. Even when we tell there are four important causes for stroke, in some patients you can see one or two mechanisms together. Like if you take septic shock, there it is actually hypotension is there due to hypovolemia, distributive shock is due to vasodilatation, and cardiogenic shock is there due to reduced ejection fraction due to global hypokinesia, and obstructive stroke can be there due to some pulmonary vasculature pressure like ARDS or something like that. So some patients can have all types of mechanism in stroke. Some patients can have definitive mechanism like anaphylactic shock. Everything else will be normal, but patient have severe vasodilatation. Now obstructive shock, the major cause for obstructive shock in our practice is pulmonary thromboembolism. When pulmonary thromboembolism occurs, pulmonary vasculatures are blocked. From the right ventricle, there may not be very good pumping towards the left side of the heart. That will produce obstruction. So pulmonary thromboembolism, whether it is chronic or acute, and sometimes it can produce by severe pulmonary hypertension also. But chronic pulmonary hypertension, chronic pulmonary thromboembolism, all are chronic diseases, so they may not come to emergency room. Then next one is tension pneumothorax. Again, the pressure in the intrathoracic cavity is increased, and that will prevent the flow from the RV to the pulmonary circulation. That will produce reduced circulation to LV, and ultimately patient develops shock. Pericardial tamponade, heart will have difficulty in dilatation, so relaxation, sorry, not dilatation, it is relaxation. RV will have difficulty in relaxation, so less blood will go to the RV, then less blood will go to the LV. From there it will not go to the peripheral circulation. Ultimately patient develops hypotension, shock. Constrictive pericarditis, again mechanism is same like pericardial tamponade. Restrictive cardiomyopathy, that also will have similar pathology. So here in large three causes, it is due to reduced relaxation of the ventricle. When there is a reduced relaxation, the amount of blood which is coming to the ventricle is reduced, so the output also reduced. That will produce hypotension, shock, all these things. So these are the common causes. In that, remember, pulmonary thromboembolism is one of the most common cause for acute obstructive shock. Now next one is distributive shock. Distributive shock means characterized by severe peripheral vasodilatation. When there is vasodilatation is there, and if even if the output is very good, there will not be adequate circulation to peripheral tissues. That produces features of shock. So distributive shock can be due to conditions like anaphylactic shock. The most important shock in that category is anaphylactic shock. Anaphylaxis to some material like food induced anaphylaxis, drug induced anaphylaxis. Suddenly patient develops vascular vasodilatation and vascular collapse. Second common problem is neurogenic shock. Neurogenic shock means whenever there is a problem to the sympathetic pathways or autonomic pathways, especially when there is a spinal trauma, injury to the spine, especially in the thoracic spine, patient can have acute hypotension because of vasodilatation. Especially chest trauma, you can see some patients can have trauma, can have dual mechanism for hypotension. One is hemorrhagic shock. Second one is after correction of the hemorrhagic shock, you can see that patient is having hypotension. That may be due to the thoracic spine injury, that is due to the disruption of autonomic pathways, and that produces increased vasodilatation. Endocrine shock, adrenal failure is the most common thing. Adrenal failure in our practice we see mainly in sepsis, secondary adrenal failure, or some patients who is having tuberculosis, they can have TB adrenalitis, or any other cause for adrenalitis also can produce shock. Abdominal compartment syndrome occurs whenever there is peritonitis or severe abdominal trauma or bleed into the abdomen, tensed abdomen. All these things, when there is a pressure in the abdominal compartment increases, it compresses the IVC and other vessels in the abdomen, and the flow to the RV or RA will be reduced. Same problem can occur in gravid uterus also. Patients who are pregnant ladies, you can have similar findings. Now, hypovolemic shock is one of the important cause for shock. Everyone know that it can be due to trauma, bleeding, surgery, hemorrhagic shock, gastrointestinal losses like severe diarrhea, vomiting, extrarenal drainage, skin losses like heat stroke, burns, dermatological condition which loses large amount of proteins like Stevens-Johnson syndrome, renal losses like excessive diuretics, salt wasting nephropathies, hypoaldosteronism. Third space loss is again very important, that here the patient loses body water into the body spaces, either abdomen, muscles, or compartments, wherever it is. So these are the common causes for hypovolemic shock. Either water is lost to an external space through the renal system or the GI system, or the patient loses water inside the body from the intravascular compartment. Whatever it is, there will be intravascular volume loss. That is very important. Now next is cardiogenic shock. It is defined as severe depression of cardiac index and sustained systolic arterial pressure despite an elevated filling pressure. So there is cardiac either there is a reduced cardiac output, or heart is not able to pump against the demand. Both are possible. So it can be a low output failure or high output failure. Low output failure means left ventricle is not able to pump properly. It is mostly seen in ischemic heart disease. Other one is high output failure, like all peripheral circulations are exaggerated. For that demand, left ventricle is not able to pump. That demand is not met by the left ventricle. So in both conditions, it is demand supply mismatch. Cause are acute severe myocardial infarction, severe aortic mitral regurgitation, rupture of interventricular septum, myocarditis, acute massive pulmonary embolism, cardiac tamponade. All these things are pump failures. Again, patient who is having high output failure, you can see in anemia in pregnancy, severe anemia, or patients who is having beriberi. All these conditions, there will be high output failure. Whatever it is, left ventricle is not able to pump against the demand, and ultimately patient may go to shock. Now, whenever the patient goes into the shock, that condition where the peripheral circulation is not getting adequate oxygenation. So in that, cell hypoxemia can occur. Energy deficit will lead to anaerobic metabolism. This is a very important step. Patient develop anaerobic metabolism. The end product of anaerobic metabolism is lactic acid. That will produce metabolic acidosis. This metabolic acidosis produces peripheral vascular constriction, and that peripheral and central both, and that constriction can produce further further reduction in the internal circulation. And metabolic acidosis, cell membrane dysfunction can occur. Intracellular lysosome increases digestive enzymes. It produces sodium potassium pump alteration. Toxic substances enter to the circulation. Capillary endothelium damaged. That is very important step. Capillary endothelium is damaged here. Initially there was only problem in the perfusion that leads to the capillary endothelial damage. In that step, patient loses large amount of volume from the intravascular compartment to extravascular compartment through this damaged endothelium in the blood vessels. So that ultimately it produces again further reduction in the perfusion and cell death. Now we will see what are the clinical features of shock. The most important clinical feature will be tachycardia. Most of the patient who is having shock will have a tachycardia. That is the first step of the shock, and it's a compensatory mechanism also. Heart is trying to compensate against the failing circulation. It increases the heart rate, so that tachycardia is the most important finding. So after that, if the patient is if the BP is not improving, then slowly the patient develops hypotension. Before that, some patients can have postural hypotension. On standing posture, the BP can be low. Then severe hypotension occurs, systolic BP less than 100. Then if you examine the patient, you can see cold, clammy skin. Patient will be tachypneic. Tachypnea can be due to various reasons. It can be due to fever, it can be due to hypotension, it can be due to sepsis, it can be due to cardiac failure, pulmonary edema. So many reasons can be there, but whatever it is, most of the patients will have tachypnea. And many patients will have drowsiness, confusion, irritability. These are all are due to reduced blood supply to the brain. So all these features can be there in many patients. Oliguria, again, reduced kidney perfusion produces oliguria, and urine output will be less than 30 ml per hour. Reduced or elevated JVP, that is also very important. Elevated JVP is seen in cardiac failure. Reduced JVP is seen in severe hypovolemia. And in that type of patients, we can put a central line and see what is the actual central venous pressure and central venous waves. Many patients can have clinical features or lab investigation features of liver failure, like SGOT, SGPT can be elevated, PTNR can be elevated, albumin can be low. In that, albumin is a very important factor because it's a negative inflammatory marker. All other inflammatory markers like CRP, procalcitonin or ESR, thrombocyte count, all are positive predictive values. Their rate increases in a severe shock, but whereas albumin has got a negative predictive value. When the albumin is low, that is a bad sign. Now, poor altered cerebral function, hypoxemia, hypothermia, all these things also can occur in many patients. Now, there is an index called as shock index. Shock index is defined as the heart rate divided by systolic BP. It has been suggested as a marker that it can be used to predict the severity of hypovolemic shock. That's all. It can predict the severity of hypovolemic shock. No shock if shock index is less than 0.6, mild shock 0.6 to less than 1, moderate shock more than 1 to less than 1.4, severe shock more than 1.4. So this shock index can be tried in cases who is having hypovolemic shock initially in ER. Now, other findings in hemorrhagic shock, that is very important. Hemorrhagic shock is classified into class 1, 2, 3, 4 according to the percentage of blood loss. So less than 15%, 15 to 30%, 30 to 40%, more than 40% will give you different classes. In that, various changes can occur, like we previously discussed. Patient can have hypotension, tachycardia, tachypnea, altered mental status, renal failure, shock, all these things can be there. And again, treatment depends on the shock stages, so the class of shock. And one of the major treatment for hemorrhagic shock, initially like any shock, we always give, we try to give crystalloids, that is normal saline or ringer lactate. But after that, if the patient does not improve or if he is deteriorating, we have to give blood transfusion, packed cell transfusion. When some patients require massive transfusion, that sometimes create problem because there will be dilutional coagulopathy. Many patients who is having severe bleeding, they lose all types of blood cells. They lose RBC, they lose WBC, they lose platelets, they lose coagulation factors, everything during bleed they can lose. But we will be normally transfusing only RBCs, so that should be avoided. We have to give 1:1:1 ratio, like you can give RBC, you can give platelets, you can give coagulation factors in 1:1 ratio, that is FFP, 1:1 ratio. 1:1:1, RBC 1, platelet 1 and FFP 1. That is called as massive transfusion protocol. We are not going to the details of that now. Now other lab investigations, you can see the blood counts can be very important. This one in very important investigation in shock. You can see some patients can have severe anemia, they can have shock. Anemia should be corrected. In septic shock, either you can get leukocytosis or leukopenia. Blood sugars are very important. Decay, you can get severe acidosis with shock because of volume depletion. Peripheral smears are very important because many findings like hemolysis, malignancy, all these things can be picked up. Malaria can be picked up by peripheral smear. Hematocrit is a very good indicator for hemoconcentration. LFT, RFT, prothrombin time, INR, APTT, fibrinogen. Fibrinogen is a very important finding in diagnosing DIC, disseminated intravascular coagulation. If PTINR is elevated, APTT is elevated and fibrinogen levels are low, we have to think that patient is going for DIC, disseminated intravascular coagulation. So that's a very bad prognosis state. So we have to be very careful. All electrolytes should be done in patients who is having shock. D-dimer can be tried if there is a suspected pulmonary embolism. If D-dimer is negative, and we can possibly rule out pulmonary embolism because somebody is having a obstructive shock and we are suspecting pulmonary embolism. If D-dimer is positive, there are a lot of differential diagnoses, like it can be positive pneumonia, pulmonary embolism, myocardial infarction, sepsis. But if it is negative, we can possibly rule out pulmonary embolism. Blood urine culture should be taken in septic shock. ABG should be done in all patients who is having acidosis. Now another important bedside test is capillary refill time. This is a very important clinical examination step in emergency room. So if there is a delayed capillary refill time, then we should suspect that the perfusion to the peripheral tissues are reduced. So always try to do this test, capillary refill time. If it is delayed, there is reduced perfusion. Next one is passive leg raising. So a patient will be lying down on bed, suddenly lift the lower limb, you can see the pressure increases, pulse pressure increases. That indicates patient can be given more fluid. So what happens is, when you lift the lower limbs, the blood in the lower limb can come to the internal circulation and it can slightly increase the BP. That indicates patient will be fluid responsive. This is only a bedside test. We cannot exactly pick up which all patients require fluid, but this gives a reasonably good indicator for fluid responsiveness. So passive leg raising can be done in any emergency room, even if you don't have major investigative tools like ultrasound abdomen, you can do this test. Next one is IVC compressibility. Any good emergency room will have ultrasound nowadays. They can do IVC diameter. If it is less than 2 centimeter, that indicates patient will be fluid responsive. Again, IVC collapsibility more than 50% also indicates patient will be fluid responsive. So if you have a ultrasound, then you can go for IVC collapsibility and diameter and pick up which all patients may respond to fluid. Now serum lactic acid is a very important tool in anaerobic metabolism. You know that most of the shocks the internal circulation is reduced and patient will go to a condition that is anaerobic metabolism. Normally when you have good oxygenation to the tissues, we have normal aerobic metabolism. But when the oxygen levels in the circulation is reduced or oxygen supply is reduced, cells go for a condition that is anaerobic metabolism to produce ATPs or to produce energy. But when the oxygen is reduced in our blood, it can go to anaerobic metabolism and produce lactate as an end product. If the lactate levels are increased more than 2 millimoles per liter, you call it as lactic acidosis if it is associated with acidosis. So serum lactemia and lactic acidosis if it is associated with acidosis, and if the lactate level more than 4, it is a bad prognostic sign. Now other investigation, like all patients who is having shock, we can do cardiac enzymes. You know that whenever there is a reduced supply to the internal organs, heart also will be involved. Reduced blood supply to heart can increase the cardiac enzymes like CKMB or troponin T, and when there is reduced kidney function, that can aggravate the problem. So CKMB, troponin I, BNP, all these things can be done in emergency. Chest X-ray, ECG, echo all can be done in associated comorbid conditions. No, ultrasound, we have already told, ultrasound abdomen in ED can pick up many problems like RV collapsibility, RV dilatation, LV failure, and IVC. So many abnormalities can be picked up by ultrasound machine in emergency room. Now once you diagnose shock, whatever may be the cause for the shock, if IVC is collapsible or passive leg raising test is positive for further fluid challenge, we can give fluids. Only if there is an intravascular volume overload, we cannot give fluids. Suppose the patient is having severe ascites, the abdomen is full of fluid, but if you see that intravascular compartment is having reduced fluid, then also we can give fluids. So don't think that ascites patients or peripheral edema patients we cannot give fluid. We can give fluid provided that either his JVP has to be low or his IVC should be collapsed, or passive leg raising test, systolic BP increases. Whatever findings you are getting, you can give fluids. For that, we have to always put 2 large IV cannulas. That is very important. Do not forget to put IV cannulas whenever we are managing shock, because any time patient can collapse, and once the patient collapses, we will not be able to put any IV lines. So put at least 2 IV lines in a patient who is having shock, suspected shock. And choices are 2. One is crystalloids, other one is colloids. In crystalloids, we have 2 choices. One is normal saline, ringer lactate, or you can even go for plasmalite. But commonly used fluid is normal saline. Normal saline 30 ml per kg can be given, and or ringer lactate also can be given. Ringer lactate can be given in almost all conditions. Even there is a lactic acidosis, we can give ringer lactate. Only if there is severe liver failure, we should avoid ringer lactate. Plasmalite is another IV fluid, which is most physiological IV fluid, that also can be given. Colloids, only 5% albumin is advised, not other types of colloids. Albumin can be given only after once you give normal saline or ringer lactate. Once you build up the intravascular volume, we can give albumin and try to retain the volume inside the intravascular compartment. But albumin is very costly. Or if you are not calculating 30 ml per kg, or if you have doubt in patient's cardiac status, you can give a bolus of 500 ml and see what happens to the patient. If the patient improves in BP, then it is a good sign. If the patient develops pulmonary edema, hypoxemia, bilateral basal cramps, do not try to give fluids in that type of condition. Otherwise, safely you can give 500 ml normal saline, even if the patient is having slightly fluid overloaded state. Because what we have to understand is fluid overloaded state can be 2 types: extravascular fluid overloaded condition like severe ascites, pedal edema and all, only extravascular compartment is full. Most of the time intravascular compartment will be empty. That's why the patient is developing hypotension. In that type of patients, you can safely give any amount of fluid, but you have to always monitor the patient. The next one is lactate clearance. If there is a good lactate clearance after fluid resuscitation, then it's a good sign. If you are giving a 30 ml per kg fluids and continuous infusion of fluids, initial lactate is if it is it is 10, now after 2 hours it has dropped to 6 or 8, that's a good sign. That means internal perfusion is good after the fluid resuscitation. So lactate clearance can be calculated, lactate initial minus lactate after 2 hours by lactate initial into 100. That if it is very good improvement, at least 10% improvement, that gives a very good clue that patient is responding to your fluid resuscitation. Now once the patient is given fluids, you can try vasopressors. In that, most important vasopressor is noradrenaline. 0.05 to 5 microgram per kg per minute infusion can be started. If the patient improves with noradrenaline and if the patient is having cardiac failure, you can add dobutamine to the regime. If there is a cardiac failure, add dobutamine. Otherwise, if the patient is improving with noradrenaline alone, that alone is enough. If the patient does not improve with noradrenaline, and if the patient is not having cardiac failure, if the patient is having bradycardia, add dopamine as an infusion. If the patient is having tachycardia, you can go for vasopressin. So different type of vasopressors are there. Try to keep the mean arterial pressure target 65 or above. That is very, very important when we are starting vasopressors. So these are the commonly used vasopressors in emergency room. You can use noradrenaline, that is the most important vasopressor, then dopamine or dobutamine or vasopressin. So depending on the clinical scenario, you have to select. Now anaphylactic shock, you know that it is most important drug in anaphylactic shock is IM adrenaline. Half the dose you can give IM adrenaline in an adult. And if the patient does not improve with that, you have to continue as an infusion in some patients. Along with adrenaline, you have to give chlorpheniramine maleate, that is an anti-allergic drug, and hydrocortisone to prevent further attacks of the anaphylaxis. Now, in pregnancy, we have to be very careful whenever patient come with hypotension in pregnancy, whatever may be the cause, keep the patient slightly on the lateral position. That will reduce the pressure on the IVC and other blood vessels in the abdomen. So slightly shift the patient to left side by keeping some pillow under the abdomen on one side, right side, so that patient will be lying down on the left side. That can reduce the pressure on the major blood vessels in the abdomen, and it itself can improve the BP in pregnant ladies. Other drugs, steroids are mainly used in adrenalitis or in sepsis, even after correction of the initial fluid balance and noradrenaline. Third line drug, you can give hydrocortisone 50 mg every 6th hourly. Glucagon can be used in patients who is having shock secondary to beta blockers. And signs of good perfusion is always very, very important. There are a lot of signs, but everyone can monitor the urine output. If there is a very good urine output more than 0.5 ml per kg per hour, that's a very good sign of good perfusion. Again, mean arterial pressure can be kept above 65. Try to keep it. Lactate clearance we discussed. pH should be normalized, and improve in consciousness should be there. Central venous pressure should be maintained, and other findings like SVC, oxyhemoglobin saturation at SCVO2 at more than 70%. These are the important things which can tell you that the patient is having good internal perfusion. So we have discussed about one of the most important problem in emergency room. There is shock and its management. There are different types of shock, but whatever may be the type of shock, the management in emergency room is always IV fluids, noradrenaline, steroids, like that. Most of the condition, these three drugs will help you to stabilize the patient. In anaphylactic shock, you may have to use adrenaline and anti-allergic medications. Thank you.